Good morning to everyone. Today we're going to present some of the technology with examples from the IMDS that is sponsoring this meeting. I have to thank them for inviting me. So my target would be to talk about the balloon uncrossable lesions and how you tackle with them, specifically designed with a device, the Blimp balloon, developed by the IMDS. So the definition, because for everything when you talk about, you have to define it, is the inability to cross the lesion with the first balloon after successfully crossing CTO with a guide wire. The incidence of the balloon uncrossable CTOs are identified, and they are around 5 to 6% in different sessions. So it's an entity that it's not so rare, and you saw the best example yesterday in the case of Dr. Werner, how far it can go. And with various algorithms and various treatments, they can success can reach up to 90%. The purpose of today is to present you a very novel balloon and very novel technology, which is called the Blimp. This is a balloon that has several very nice characteristics. From this figure, and I'm going to tell you about more specifications, you can appreciate that it is a balloon that combines CTO and the scoring capacities. It has a very short monorail snorkel, which is around 5 millimeters, and then the wire gets in there, exits in front of the balloon. The balloon is 0.6 millimeters in diameter and 0.5 and 5 millimeters in length. And then it has the shaft with hydrophilic coating in the first 20 centimeters and the usable length of 150. You can appreciate here in these close-ups how it is a guide wire, the small tip monorail, and the balloon behind it. And that's how it is working inside the vessel. You see that the wire is outside the balloon, and then when it's inflating, except the pressure that the balloon exerts, it is also exerting an additional pressure to the vessel wall because the wire is pushed against it. It has the proprietary technology also of IMDS. There is a hypotube in the entire length of the balloon that is increasing its crossing capacity. So the tip very low profile with high penetration power. The balloon is 0.6 by 5 millimeters, and it can reach 30 atmospheres. The shaft is below 1.5 French, and as we said, it's high pushable. And the balloon has, as I said, the scoring elements. What is the effect of the scoring in the vessel wall is that essentially it is multiplying its capacity by 4 times by increasing the stress by 4 times. So whenever you go to 10 atmosphere, the pressure vessel gets 40. And the balloon is designed to reach 30 atmospheres, so it can, if you reach that, you can exert up to 120 atmospheres in the vessel wall, and you understand that this is big power to be able to crack even the toughest tissue. The other thing is that everybody could say so much pressure in the vessel wall, it might cause problems, but this is not the case because the balloon is very small. It's 0.6 out in diameter. And you can imagine that it is being used in tissue, that it is occlusive or highly calcified. And with such small diameter, it does need its preparation of the vessel for further treatment. We're going to go through a certain series of cases of efficacy, and I will show you how, with examples, the balloon is being used proper, and then we will demonstrate some failure modes that will clarify even better as to why the device is failing and what is the proper use. You see here a patient with a right coronary artery occlusion, quite short, with good collaterals from the right, from the left system. We started by anti-grade wiring, and the wire quickly went off. and then parallel wiring using the enhancer RX gain from IMDS, the dual lumen microcatheter. And you can appreciate the Gaia 3 wire finds out, this is an example of dual lumen proximal cap penetration and crossing. A Gaia 3 goes into the true lumen. And then definitely this catheter failed in this case to cross. Doesn't fail every time, but it's not purpose for crossing, so we removed it. And then it was by a trapid device in a 6 French, so you can see the combination of different devices in the same case. Then a microcatheter, the fine cross fails and the balloon failed in this case. So what we did is that you see a close-up of the failure of the fine cross, and then the trapid the Blimp comes. It has a very short and not very easy to see marker, and you can appreciate here the balloon is coming. I'm pushing it, and then you see that the marker, it deflects from the vessel wall and it stops there. So we brought a guiding catheter extension, the Gideon here, and we pushed it, and what happens, the balloon gradually moves forward, and then it's very hard to see it here. Essentially the balloon is crossing. It was one of the first cases, and we started understanding, it's more than a year now that we started doing these cases even further, because I was one of the first ones to get the device in my hands. And then we were saying, how is that really working? And you see this stop frame, and this is the marker that it is on the balloon. And then you can see when it's far away, the monorail, the short monorail, is just in front of it. And when you keep on pushing, essentially there is a lateral deflection of the device, and essentially you lose the capacity to move forward. In this case, we didn't realize it exactly. We put a guiding catheter extension, and we were thinking that the device is behaving in a way that, okay, you're increasing the backup support. And of course, when you have a device that has a very long monorail, that's the case. But what happened is the guiding catheter extension helped the device to propagate, and we thought that because of the backup support, but the reality is that the guiding catheter extension was keeping the device away from lateral deflection, so it was forcing it. It was all the penetration power of the design was put into the tip without lateral deflection. And then you see it here with this marker that when it's crossing, it's completely aligning itself with the guide wire. It's more difficult to see. So what we understood of that, the purpose is that this is the continuation of the case that was successful, is that you should not push the device further than the border, that it goes too far away from the device, from the wire, the balloon, because then you're having an exercise in futility just by losing your alignment with the target. So that's one of the first lessons that we learned, and then we exerted that. I'm going to show you a couple of cases more. There's another occlusion here. Cases that you're seeing, usually these devices are of this level, post-cabbage patients, very calcified vessels, and you see here a vein graft in the LAD, some poor collaterals in this case. An antegrade attempt reached where it was going to reach in this case, so we got retrograde attempts, and then because of the nature of the patient, also the retrograde microcatheter stuck over there. At that time point, the experience with the device was still growing. In my last case, I'm going to present you how we dealt with collaterals with this device again, that microcatheters were failing. Anyway, you see a very good alignment here, and the wire is there, but the retrograde microcatheter, it is not quite calcified vessel. You can appreciate from the shape of the wires. The wires were aligned, but everything else was failing okay, I thought that. Anyway, these are close-ups, so they don't work even in my computer because I don't have the capacity to interact with my screen. The device, as you say, a conventional device here failed to cross, and then the Blimp is coming here it is. You can appreciate it here. We're pushing, there is lateral deflection, and then we're raising that, we're not increasing. You see, we're keeping that up to the level that it has to be kept. And you see with the complete alignment anymore, we keep the device so much pressure up to the point that the device, you have to wait for it, keeping it aligned with the guide wire, and then suddenly you see that it propagates within the occlusion. So you don't have to push or to over push, let's put it in this way, but you just have to wait, keeping the right pressure in the device, and then slowly it goes down. That's how this case has been concluded also, but it shows you exactly that the fact that you have to be patient, you don't have to push it too hard, you have to push it up to the level that it has to be pushed, and then you have to wait for it. That's another case, a right coronary artery occlusion, quite tough as you can see. The antegrade wire went off. Again, we had retrograde access. It was so calcified that you can see the tip of the wire. It's a retrograde Gaia that it has been, the cone of the wire has been detached, so very calcified lesion over there. And again, you can see the blimp. We go up to this point. You see, we keep the wire aligned. Unfortunately, this one is not playing even now. But anyway, we followed. You can see that by keeping the alignment here, this exactly at this point is the tip of the marker of the balloon, and then essentially again we followed the same principle, and the device was crossed the lesion, pre-dilated. You don't see an immediate effect. When you cross, you will not see flow in the majority of the cases, because what you create there is a very small lumen, just enough to allow devices to go for further dilatation. That's another case here. Again, difficult patients, you will face them quite often. This was a right coronary that it was occluded exactly after the takeoff of the RV branch, and you see that there was a retrograde access directly that was applied. The proximal cap, it's somewhere here. You can see that this is a Confianza Pro that goes completely away from the target. So we followed eyes with recognition of the proximal cap over there, and then a dual lumen microcatheter was used to penetrate, but nothing was going on over there. And maybe it's hard to see here, but everything failed. And then we changed that to the blimp, and hope you can see that the device is coming here and it's crossing. Here is the marker again. You can see it going down. This case, it was far easier than the others, but everything else failed there, and then pre-dilatation followed, and the case was concluded. It's sometimes difficult to see the device, especially if the patient is big. So one of the things that makes it difficult for the presentation, you have to be focused, and you have to also, one of the things that someone has to care is when you're loading the device, you don't have to be, you have to get used to that, because the motor array is so short that sometimes the people are pushing in a way that they're destroying the device. So it's a device that needs some training. I'm going to show you a case. This is a case that's not mine, so when we got experience and the people in my lab, they showed some successes. And this is a case that I was abroad, and when I came back, he was complaining about the device. So an LAD CTO that was crossed. Our colleague tried everything. You see, he tried to put a balloon, deep engagement. He used even a guiding catheter extension. Nothing went. And then he said to me, I took a blimp, but it doesn't work. And look at that. He has the blimp there, and he's pushing in a way, if you focus on that, and you will see it even better here. He pushed so much that essentially the balloon is back there. The entire tip of the balloon has circled into the vessel, and then he knuckled the balloon, let's put it in this way. It shows that you have to be familiar with the technology in order to be able to apply it carefully. That's another case that I did. It's not a CTO because quite a lot of the times that we're facing, it's about very hard tissue, and this balloon has a very good role there. It's not only about uncrossable CTO lesions. You know that there are lesions that are not occluded, and they're very hard to do. This is a calcified vessel, and the LAD was tackled, and he had this circumflex, but it's quite tortuous in the proximal part. There is an osteostenosis there, and I would like that you focus this case, this balloon, this occlusion, this lesion cannot be tackled easily with a Blimp for one simple reason. Because the wire proximally, the vessel proximal is so tortuous, you see that the divergence of the Blimp away from the wire just because of this proximal tortuosity. So vessels that are extremely tortuous proximally from the target, because the balloon has such short monorail, it is a disadvantage, but confirms what I told you. The alignment with the wire is the major issue here. This specific lesion was rotablated, and it was finally successfully treated. I'm going to present you now my last case, and it's for a completely different topic. So this is a case that is an occluded LAD. It was tried in the before. They have dissected the left main, and they stented it, and the patient came on the table for a second attempt in his LAD. The lesion was crossed retrogradely with the collaterals were easily accessed. There is a carable microcatheter, as you can appreciate there. So this was successful wiring. I will not insist on that. You see the wire down. And everything failed. The microcatheter failed. It was impossible to go beyond this part. So we did a balloon, and everything failed. And we used second or third microcatheter there, and nothing was working. So you see the Blimp in this case, it's much easier. That's how a balloon, if the patient is a little bit lighter, you can appreciate that he can, you can see the device here. You see the marker that's going up. There is some resistance there. You see it in a close-up as it works here. And then by keep on pushing, you see that it makes a quick move forward, and then it's crossing. And with all dottering effect, there is no dilatation here. It's not necessary. You see it here. This is a classical way. The balloon is crossing, and then the microcatheter is easily following, as you can appreciate. And the case was concluded by reverse wiring through the stent. And I'm going to finish by showing you another case like that. Again, these very difficult patients. This was actually the very first case that we thought of doing it. People are pushing now the balloons completely retrograde for dilatation of uncrossable lesions for retrograde crossing. So there are many applications. You see the terrible collaterals that they have been crossed over there. And the wire reached a very complex right, and nothing was moving. We tested 3-4 microcatheters at that time. Even you can see another one here, small balloons, nothing. And then with guided catheter extension, you will see the balloon is coming here. You see it going down, and then it's a pressure here. I'm giving a close-up. You can appreciate it here, and then again it jumps. In these kind of collaterals, there is always a resistance that someone cannot appreciate, but it's always focal. You see the close-up here. The balloon is coming, and then it just jumps again, as in the previous case. What happened in this case, it's very interesting. There was this very focal hematoma that has been created, and this was the only one. We have now 20 cases. We're preparing a publication. In 19 of the 20, the balloon worked very nicely, and this was the worst complication. We had only one failure to cross with the Blimp collateral, so for me at least it becomes my standard choice. Whenever I had such a problem of not crossing the collaterals with a microcatheter, I always take the Blimp, and I avoid the usage of an additional device. So you see it here in a close-up, and you can appreciate that it was crossed with a carable. And it was a terrible lesion. The final result was this one that you see, and in a second session it was rotablated undergradely, but it took very long and we were exhausted in this case. So that's the experience with the device for balloon uncrossable lesions, and we found some innovative also other techniques to improve our retrograde skills and effectiveness and safety. Thank you.
Just a comment on your great presentation. I think that you explain really well the use of this fantastic device. I think that make the difference some situation like my live case of yesterday, which I burst 4 or 5 balloons and then was not able to cross this calcified lesion. And the use of Gideon, and I used for the first time the new Gideon Hydro is fantastic. I was able to cross until the calcified lesion, and the Blimp easily cross. Just to let you explain that sometimes when you push with the Blimp and you're not able to cross completely the lesion, it's very useful to dilate and then to deflate and push, because the profile is so small, then you can also have this advantage. Would you agree with this technique? I think that's... And also your case on retrograde application, sometimes we can be a little bit worried about this device because it have a strong tip, but you show that we can use also in this particular field.
We didn't have any complication. As I explained, it's 22 cases now. We were always cautious, but I presented you the case that it had this focal aneurysm. All the other cases, they went very smoothly. And we understand better the nature of the uncrossability of the collaterals because it's always very focal. There is a spot over there that when you go through it, and then it's essentially releasing the collateral. You see always this jump. So in these kind of collaterals, for whatever the reason is, there is this focal resistance, and that's why the device is
your experience...
and we don't dilate with the Blimp. So there is no any radial. We never dilate. Not because there's going to be a problem, but it's not necessary.
So in your step-up approach in this septal, for sure, I think you don't use in epicardial. I think that it's...
No. We talked only about septal collaterals, yes.
To explain that it's not allowed for epicardial. And in your step-up approach, you change microcatheter, or you try to dilate with small balloon, or you go directly with Blimp?
No. I always anymore use the Blimp. Always. After the first 5-6 cases that we show this success. And actually, a couple of years in Toulouse, we did a live case like that in front of an audience, in front of the EuroCTO club meeting. So it has been also demonstrated live. It's always working very nicely. And I have no hesitation of safety there. Absolutely not. The major problem comes when you push other devices through collaterals rather than when you cross it. The device, it has very high penetration capacity, and in the septals, there is a benefit because they're so small vessels that the device cannot laterally deflect. It's by default restricted by the muscle to keep all its penetration power forward.
So it helps the...
Exactly, because the vessels are too small.
So small. Yeah, this is an important point. Yeah. So thank you very much.
Thank you.